You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is July 25th, 2025. We are doing our orientation series, and our topic today is asthma. This was presented by Dr. Salman Aljubran, who's an associate professor of pediatrics and is the associate program director of the Allergy and Immunology Fellowship at Children's Mercy Hospital in Kansas City.
Yeah, like we did last week. We'll start again. 1, 2, 3. Ready? Let's go. Okay. So, good morning, everybody. Today is Friday, and this is the second hour of COLA summer series. We're going to present today asthma overview, and my name is Salman Aljubran, one of the staff of faculty at Children's Mercy Hospital, University of Missouri, Kansas City, UMKC. And we're going to start with a clinical vignette, and this is going to be simple asthma talk, like I said earlier, like 1.1 or 0.1. Just get you.
It's not moving. We're just silent.
Okay. That should. Is it delayed or it's? This is the one we have here. Stuff we're sharing, but that's why it does not present. Sharing the window. So how is
Go back to the PowerPoint scan.
this is the quick we have to. No. Why does not?
It says it's sharing this screen.
Yeah, maybe. Try presenting it again.
Let's see. I mean, it's okay. Sorry. We move like this, that. That's it.
Not just like delayed or what, but this is just an issue.
When you go to presenter view, it's not sharing that.
It does not show, so we should not do the present view. Maybe that could be safer. Wait, let me see if I do, or maybe manually moving it. Try to. Does it move?
Now I'm using.
Oh, okay.
Maybe just some paper there. Yeah.
That's good. Yeah, sure, definitely. I don't really well projected.
Yeah.
Cool. Awesome. Let's see. Oh, cool. Awesome. All right. Let's start with clinical vignette. We have a 2-year-old male with history of respiratory distress, wheezing, admitted to PICU, found to have RSV infection. He had another episode of wheezing, needing ED visit, otherwise doing well in between, and kid is gaining weight appropriately, no concern about his weight. We have a second case where a 7-year-old female with started to have cough at night and while playing soccer outside in springtime. Third vignette, we have a 14-year-old female with history of difficulty breathing with prolonged activity, otherwise she's doing well. The last one, we have a 23-year-old male with history of allergic rhinitis, experiences wheezing and chest tightness 4 times, up to 5 times a week. And he does use albuterol, and he does notice, gets under control while using albuterol. So what is asthma? So the more you know about asthma, the difficult to define asthma, to be honest with you. It has a lot of, let's go, yes, we've got to have to go this way. So asthma, as you can see here, it's really, I define it as a syndrome and characterized by presence of chronic inflammation resulting in airway obstruction, bronchial hyperresponsiveness that cause wheezing, coughing, dyspnea, or chest tightness. The other definition, or the EPR, the National Asthma Expert Program Panel Report 3, define asthma as a complex disorder characterized by variable and recurring symptoms, airway obstruction, bronchial hyperresponsiveness, and underlying inflammation. The interaction of these features of asthma determines the clinical manifestations and severity of asthma and the response to treatment. The GINA guidelines or defined asthma as a heterogeneous disease characterized by chronic airway inflammation and defined by respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and intensity together with variable expiratory airway limitation. So really what we get out of this is that asthma is a chronic problem, chronic inflammation. You have symptoms such as wheezing, coughing, chest tightness, dyspnea, maybe plus or minus that, but they are not specific. But you have to have what you call a flexible air obstruction, not fixed air obstruction. This is the natural asthma definition. Asthma is a chronic disease as well, and it's non-communicable in this country and worldwide. It affects more than 300 million patients or person worldwide. About 19 million in the US, adult US patients will have asthma, and 5.5 million children will have asthma. Prevalence may be 7.7 in the US. It is one of the most common chronic disease in kids. 3 or up to 10% of patients with asthma would have severe asthma, and their care is estimated to account more than 60% of the cost associated with asthma and primary for medication. So it is a chronic problem, and definitely in asthma clinic, you're gonna see a lot of asthma patients, right? And few months you're gonna see a lot. Sometimes I have 10 out of 12 asthma kids coming either new eval or follow-up. So it is important to understand asthma, how to obtain a good history in order for you to diagnose asthma or asthma, roll out asthma mimickers that we can talk about more. So the first thing start is symptoms, right? So we're going to ask about the symptoms: cough, wheezing, chest tightness, whether you have shortness of breath. Usually cough indicates inflammation and wheezing indicate obstruction, and difficulty breathing might indicate both. You can ask about the frequency. How often do these symptoms occur? Do they occur on, like, say, maybe sometimes once a year, like when it's cold, once, twice a year, or maybe they happen multiple times a day? You have someone who's been having issues, let's say someone has allergies, they have dog allergy, and really severe dog allergy, and they have multiple dogs at home, so maybe symptoms happens like multiple times a day. So symptoms can vary from once or twice a year to like multiple times a day. So you have to identify the frequency of the symptoms that can help you to determine the severity of the symptoms as well. Triggers, we're going to talk more about triggers because there are a lot of triggers that you can encounter. There's stuff that you can control, there's stuff that you might not be able to control. We'll talk more about that. You need to obtain more information about treatments. So what did the patient receive for treatment? Yeah, having cough, and whether it's upper airway cough or cough variant asthma or something else, then what type of treatment were given, and whether these treatments did help with the symptoms or did not. Did they need, let's say, oral steroid or systemic corticosteroids once a year, or like they have it every 3-4 months? That can help a little bit determine the severity of the asthma. You ask or inquire about ED, urgent care visits, how often, and what type of treatment been given. Definitely, hospital admission will indicate how bad the symptoms were when they had their symptoms, and you would ask about ICU and intubation. And it's good for PEs to take like post-delivery, like history, whether it be in NICU, prolonged stay, intubation. That can deliberately affect the outcome and your differential diagnosis for these patients. All right, asthma triggers, the common, you have allergens. You get a lot, like stuff that indoor or all year round, and you have something seasonal like pollen. So you would inquire about dust mite exposure, about pollens like spring, summer, fall, mold, cockroaches, and pest dander, and sometimes rodents if you have that an issue. You would ask about respiratory infections. RSV is one of these common viruses that we see in asthma, and RSV will make you wheeze. So it is common that everybody might wheeze when they get RSV, but RSV is a risk factor for asthma in the future. So it doesn't mean that you'd have asthma, but it increases risk of having asthma. The other virus that we usually encounter is rhinovirus. It is not as bad as RSV, I would say, but if you wheeze with rhinovirus, then you might suggest maybe underlying asthma, or maybe you're going to have asthma in the future. But RSV and rhino, this common infection that we see, and might increase the risk for asthma in the future. Exercise, definitely, you can see exercise-induced asthma, or sometimes exercise-induced bronchospasm. Cold air exposure, smoke, tobacco smoke, air pollution, strong odors, and sometimes in some patients, stress and strong emotions might trigger asthma, say loud laughter or crying. That could be something that sometimes might help you if you ask that right question to whether this is asthma or not. Comorbid condition, because asthma can exist or coexist with other disease, and we always ask about comorbid conditions because sometimes treating the comorbid condition, that's what you need to get asthma under good control. The most common comorbid conditions associated with asthma: rhinitis or allergic rhinitis, GERD, obstructive sleep apnea. Obesity is one, and even an anxiety and depression might worsen asthma symptoms. So that's stuff that you always want to ask and inquire about, because treating these might help with asthma treatment. So sometimes stepping up with asthma treatment is not what you want to do. Maybe you want to address a comorbid condition and help them with, say, avoiding allergen that might help with asthma symptoms. And you do need to step up the treatment. This for asthma. Asthma is a clinical diagnosis. Age is not a factor. You can diagnose asthma at young age, you can at old age. So I know in the past, or the old, I don't know, it's a myth that people cannot diagnose asthma until they're older, but you can have diagnosis up front at an early age. The test that we have to help us to diagnose asthma, or confirm asthma diagnosis, but it's not really the only thing that you need to do to diagnose asthma. So if you see a kid like 4 and they cannot do pulmonary lung function test, you cannot think, oh, I cannot diagnose with asthma if they have clear symptoms suggest or support that diagnosis of asthma. So Spiro or PFT helps with flow, airflow. We have a fractional exhaled nitric oxide or NIX, and usually associated with inflammation, eosinophilic inflammation or type 2 kind of asthma. Definitely, these are the most common that we use on at least on daily basis on our clinic. Peak flow is something or that you can use. It's not as accurate, but if you have nothing, but still can be used. And if you're concerned about occupational asthma, that might help adult patients, say if there's changes at work versus at home, or you're in the weekend you're not working. If you have patient have history clear asthma but Spiro is normal, then bronchoprovocation like methylcolon challenge is something that you would consider and you might do, and be able to have it done during the main hospital. For PFT, we're gonna have a lecture dedicated for PFTs, and you're gonna learn a lot about PFTs. It's the gold standard for diagnosing airflow obstruction and evaluating reversibility. As you can see here, now the new criteria is different from the old one, and the question comes in about z-score and 2 standard deviation, different changes that could be either abnormal or normal, but still the reversibility that you need to know that FEV1 or FEVC, if there's increase more than 10% or 10% or more after using the bronchodilator, that will support obstructive airway flow kind of disease like asthma. So that's something you'd look into. The old criteria was about more than 12 plus 200 ml changes in FEV1. The thing that you need to know, having normal Spiro does not exclude asthma, especially in someone who has mild or intermittent asthma, or they're doing well on their medication. So I'm not going to dive in deep in this because we're going to have a separate lecture just for PFT indication, interpretation, and other modality of asthma evaluation testing. Moving on to nitric oxide, it helps in diagnosis of asthma or support diagnosis of asthma, especially in patients who have normal Spiro. Can predict response, because usually if you have elevated NIX, suggest that the patient might benefit from starting inhaled steroid or similar medication. The classic situation that you might see like a 5-year-old patient coming to your clinic with cough, but no history of ATB. Sometimes the activity may not, and you're not quite sure this is asthma, this is upper airway cuff syndrome, and you're trying to say like, okay, can I should I start nasal treatment or should I start inhaled steroid? So if you I'm usually 5 and older, this one you can get NIX. And you always try, but sometimes we may not be able to get it. But the age 5, this is when you start to think about NIAX. If you get it and you see that their NIAX is elevated, then they might benefit, or this kid might benefit from starting the steroid or similar medication. To say if NIAX is normal, then you might lean toward just addressing the upper airway cuff syndrome and maximize nasal treatment and reevaluate next visit, and hoping that will do the job. How can we use NIAX for adherence? Because if you see patients who's taken inhaled steroid or medication coming up for a visit and you have a prior NIAX level, if the NIAX is elevated, indicates multiple things. Could indicate asthma control patients not getting enough from the medicine, and they may need just step up their treatment, or maybe not taking the medicine. If they're prescribed like budesonide inhaler and they're not taking it, NIAX should be still elevated. So maybe they're not doing it, or sometimes maybe they're using the inhaler but not using a spacer. So that's why we want to make sure that the medicine gets to where it's supposed to work in order for you to see a difference, right? If you see a patient for follow-up and you have NIAX and they say last visit was 84, today about 24, then that's remarkable change, and that suggests that they're either improving or they're really taking their inhalers as they're supposed to. Can help when phenotyping, especially when severe or moderate asthma, can help you to consider what type of biological agent you might consider for your patients or suitable for your patients. So we have a couple of cutoff numbers or criteria for NIAX, and usually based on age. Children's indicates that kids below the age of 12, adults or 12 and above would consider adult for the sake of interpretation for NIAX. So for children, anything below 20 indicates low, and this could suggest either unlikely eosinophilic inflammation or they're doing good control if they're follow-up, right? If they're more than 35, that indicates that there's eosinophilic inflammation, or maybe they would benefit from taking a steroid for maybe asthma. For adults or 12 and above, the cutoff going to be less than 25 going to be low or normal. Above 50 would be abnormal. And you can see in the middle here we have a little bit of a gray zone or intermediate, because you see patients like 8-year-old and you end up obtaining NIAX and their numbers is, let's say, 28. Then this is not below 20, not above 35, so that would be a little bit into the intermediate zone. And you have to know that nitric oxide, the gas that you measure, can be produced by other stuff. Let's say if you have sinusitis or like rhinitis and your asthma not controlled and your nasal allergies acting up, then that can contribute as well to the major NIAX. You always ask about food because the esophagus close to the trachea as well, right? So the oropharynx could be from sinuses, from lungs, or from your stomach. So other factors can contribute to the elevated NIAX. So you always ask about, nasal symptoms, rhinitis, that control, or what did you have today, breakfast in the morning or for lunch? This I got McDonald's, half an hour before on the way here, and get nuggets, get cheeseburger, a lot of stuff that contain nitrate, then that might contribute a little bit to the elevated NIAX. Because sometimes, ask about asthma symptoms, they're great, and why I'm having a little bit of elevated NIAX? Then you have to take in consideration other factors that might contribute to the elevated NIAX when you do the procedure. And if you're gonna obtain NIAX or the pheno, you want to do it before the spiral, because if you attend or see the RT, how they conduct that, they do multiple times, exhale, maybe 6-8 times. So that kind of affects the result. So ideally, if you want to obtain NIAX, make sure you do it first and then you get spiral. If you end up doing spiral, then maybe you want to wait and then maybe get a NIAX later on toward the end of the visit. But make sure most RT know this, so you would not answer it wrong. But if you get a new person, or they say your RT is not available and someone else doing the study for you, make sure they know that you start with NIAX first before spiral. So it has some utility, and for practical reasons, you might ask about the costs associated with this. And I mean, Spiral would definitely, if you have to pick one, I would go with Spiral, lung function test. Knife is really, I always tell the fellows that this is like the, when you drive a car, I mean, if it's a nice car and you have in your mirror, you have the blind spot, that's going to be a little bit good to have, right? Because you're not going to turn if that's on, and that can help you when you say you're going to change the treatment. If you say the knives are coming for you, like, oh, I think I'm going to try to step treatment. You get knives are very elevated, then maybe they have risk for flare ups, and maybe we're holding that. The same thing with the blind spot sensor that's on. You're not going to turn left or right because on you maybe there's something next to you, right? If you don't have it, you still can turn, hoping that there's no car there, right? But this is, for me, this is what usually I tell folks, like, yeah, this is what usually let them tell me to understand what's going on. So it's really good to have it, but I still can manage without it, right? But it's always good to have it. And for real life, private practice comes in, the reimbursement, that's for another day discussion. But for today, if you have the ability to do it, please do it. It does help you with asthma management and can help you a little bit to make a decision. But you're not gonna use this information solely to make the decision. You have to take into consideration the clinical pictures, other factors, before just making any kind of adjustment in the patient's plan. All right, so we said cough, wheezing, chest tightness, dyspnea, they are really non-specific respiratory symptoms. You can have that with viral infection, right? If you have normal lung function, say you have a chronic cough, normal lung function, doesn't mean they have asthma. And the classic, what Dr. Miller always say, that not everybody can take clinic with cough is asthma, right? So always you want to walk in with open mind. This could be a lot of things. If you just think, oh, I'm an allergist, this is an asthma, coming for cough, this is asthma, you're going to miss a lot. So always keep it open mind that yes, they're here to see me. Could be asthma, most likely, but doesn't mean it is asthma. So you always want to take into consideration other possibilities. Could be based on the age or exposure. Saying, yeah, I mean the current cough. So I know we don't do much X-ray with the asthma, but they say if you have somebody, an adult with chronic cough for a year, then you maybe want to get an X-ray because still lung cancer or malignancy is one of the differential diagnoses, right? So the symptoms, they're not specific. If you have, let's say, lung function test, that's a just obstructive pattern, reversible, then yeah, that goes along with asthma. But you have to take into consideration that a lot of symptoms, a lot of disease can present with similar to asthma or asthma mimickers. So you have to be careful. That's why you have to take the time to ask the right questions and make sure that you're treating asthma and not something else. And always ask the fellows that if somebody comes to you for follow-up, you want to always confirm the diagnosis of asthma. I mean, someone diagnosed them with asthma doesn't mean that they have asthma, right? Especially if they're really not doing well, like they're in good therapy, that doesn't make sense. Why you tried several inhalers and you still cough? Maybe it's not asthma, right? And you maybe look for other, I mean, what adults receive with heart disease could be something that you always worry about, not much with kids, but it's always good to know that possibility. So the idea is that please come to you with cough, don't just label them asthma up front. Yeah, even they're coming to you as a specialist. Asthma is still a possible diagnosis, but it doesn't mean they will have asthma when they walk into your clinic. So severity of asthma can be classified to intermittent, mild persistent, moderate, or severe persistent, and these are based on symptom frequency, nighttime awakening, use of rescue inhalers, and we should a little bit stay with rescue inhalers, and the preferred term is a quick reliever or quick relief medicine, better than rescue inhalers. I think that technology has changed, and so maybe you want to change or stay away from this. I keep that for that reason, to remind you just to make sure that you guys do use that term. All right, and interferes with normal activity. And as you can see, the initial treatment for asthma can be based on the severity, and subsequent treatment usually based on the level of control. So initially, if you see a patient not in inhalers, not in asthma medication, this is when you would consider or classify their severity, and that would be based on the impairment and the risk of future exacerbation. Impairment symptoms, you have the symptoms, day symptoms, night symptoms, use of short-acting beta agonist, and the level of activity limitation is mild, minor, or severe. And then definitely Spire would have some input as well for the classification. And this would vary based on age. You have 0 to 4, 5 to 11, 12 and above. So you're going to have different, because once you classify or are able to assess the severity, that would help you to for treatment wise. Step one means that's intermittent, then what type of treatment modality you're going to use based on, say, someone who's in 4 or 5, then different than they're severe, that need a lot of medication or different type of medication. So the classification for asthma control, the same thing, has the same component more or less, and this is another way from the same table earlier. And even Children Mercy, we have this available for the guidelines for us, and you can see the breakdown: less than 4, less than 5, 5, 11, or 11, and based on their age and their symptoms, impairment, risk of flare up in the future. And definitely we use what you call validated questionnaires, and that's something we use in the clinic, or called asthma control test. And there's 2 types, I should say, based on the age. 4 and below you could track, and more than that you call it ACT. And 19, more than 19 or 20 indicates good control. Less than 20 indicates poor control. Practical point that you have to be careful about this. You cannot use this as the only input to make a decision. I walked in the clinic, I see a 10-year-old filling out the questionnaire. Sometimes people are busy, didn't have time to do it. They give the kid just fill out the information. Sometimes like, it doesn't make sense. You're doing great. Your score is like 12. I didn't get it. Or I see score like 20, 21, and really just had a flare up like a week or 2. So you have to take into consideration if does the number really align or go along the history. So you have to know, because unfortunately, I mean, just this is practical, real life, busy parents, didn't chance to do it. You have to do it awesome, and then to do it, you have to clarify who did the ACT, who filled it out. So the goal for asthma management, you have 3 main goals: control their symptoms, you want to reduce the risk of exacerbation, and minimize the adverse effects of medication. So asthma management, a lot of components. It's not just about medication. Patient education. Education is very essential because you want to make sure that patients are active in their treatment. And sometimes a preference, what type of medication they will take. You have to discuss with them, because that will increase the chance of them taking the medicine, or increase their adherence with the medication, and you have better asthma control. So about education, definitely you have to spend the time with your patient to educate them about their condition and the treatment options available for them, and you make a decision which one they prefer, and that increase their adherence or chance of them taking the medicine. Definitely, because most of the medication are twice daily, sometimes asthma 3 times. Patient can do that for short term, but not long term. It is difficult. It's human nature. You cannot expect patients to do this 3 times a day for like several months, or twice a day. So definitely you have to take into consideration. Yeah, they may be initially committed and happy, but eventually they might get tired. So that's why sometimes the revisit or follow-up is very essential and very important to re-emphasize and encourage them to keep up. Oh, I'm doing well, so I decided to try medicine. Please don't do that, right? Just talk to me and wait to call us, call the clinic, send us a message in the portal with us. We can help you. So, but don't stop the medicine because I'm feeling good, right? All right. So assessment and monitoring this, like with the follow-up, and you always ask questions: what's going on? Controlled, not controlled. Other factors. You want to control the environment factors and the comorbid conditions. Yeah, coming to you every time. You always ask any exposure. Something that someone has dog or kid allergy. Yeah, we just got a cat last week, and you start to have more symptoms. So you always want to ask about their potential trigger for their asthma, and always assess the comorbid conditions. Yeah, coming to the medication. As doctors, we like to give medication, right? That's what we do every time we walk in, make 1 or 2. Sometimes patients may like, oh, I can take 5 medication, because you send them like with nasal sprays, oral antihistamines, you give them 2 controllers, and maybe plus or minus leukotriene modifiers. Patients, 5 walking after clinic. So don't think that next visit that's we are taking all this every day. There's no way, right? So you have to always consider what type of treatment, what the options, and what is the best treat for your patients. And as long as make sure that you take their input as well, their preference. So history of asthma or asthma management, we really improved a lot since the 60s, because we started with 1960s, that long time ago. I wasn't born this ago. I'm not sure my brother might. So we started really, that evolved as our understanding of asthma evolved. So initially we thought asthma just a construction or like a really obstruction. So that's why we started with the relievers back in the 60s, and then we say, oh nice, maybe there's inflammation, so we added more medication. Thiophylline, I'm not sure we still use it, but some option maybe. I have no experience with it, never had to use it, but I'm sure some had experience with it. Still an option, but not anymore. Has very narrow toxicity level, so it's really takes a lot of effort to maintain that level. So we moved the cromolyn, and this is where we had really big advancement in asthma treatment, the late 80s and early 90s, when inhaled corticosteroid introduced to the market. That was a game changer for us and for our patient. Early 2000, we have biological agent omalizumab, one of these medications that 2003 was introduced to the market, and since then we start to advance with the treatment till we got to where we have today, personalized medicine, and each one has maybe different based on a lot of stuff, phenotypes, endotypes, or genetic markers. So really took several years, but as we learn more about asthma and we start to produce or have more options for our patients and improve their quality of life and minimize the risk of having exacerbations. Right now we have that personalized asthma care. Say 90% of the time, this is what you're gonna need. Make sure you're diagnosing right. Make sure you have the correct diagnosis of asthma. You can assess the severity of asthma, and then that determine what you're gonna do with them. Assess comorbid condition, trigger factors, and treat them. It's gonna be easy, stepwise approach. Less than 10%, you might to go to what we call personalized approach, and usually this is where the severe asthmatic patients, and we're going to have a dedicated lecture for severe asthma and treatment. So I'll keep that, but stuff that you know, because you might need to identify their phenotypes. Phenotypes is just what you see based on the based on genetics and the interaction with the environments. The endotypes is just the pathways you're going to get in farmer, and that would help us to determine what the biological therapy needed for this patient. And by the end of the day, we're called tailored therapy. And that's the goal for the future medicine. All right, so asthma medication, quick relief medications, we have that, and we have long-term controllers, we have biologic therapies, we have add-on adjunctive therapy. Allergy immunotherapy could be considered biological therapy treatment. And I know that last week we had a lecture about immunotherapy. So that's separate but different. Is one of the options for patients who have allergic asthma and their asthma triggered by allergy. So allergy therapy would be a good option for them. For the quick relief medications, we have albuterol, short-acting beta agonist. Within 5 minutes, gonna work, lasts up to 4 hours. We have formoterol. This is long-acting beta agonist and acts within 5 minutes. That's why now with the smart therapy, formoterol with combo with other inhaled steroid is the one recommended for single maintenance agent, reliever agent. Ipratropium, anticholinergic, something that can be used as well. Formoterol can act up to 8 hours, so that's why it's long-acting beta agonist. Ipratropium, maybe EDers, you can use it as a combo therapy with Ventolin, but I don't use it like upfront as a quick reliever. Long-term control medications, and this is the one that expects patients to take daily. The classic is the inhaled corticosteroids. You have several medication available in the market. You have budesonide, fluticasone, beclomethasone, and many others. Ciclosinide is one of this, but we always forget about that. But we have a lot of options for our patients. We have the long-acting beta agonist, salmeterol, and acts up to 12 hours. Formoterol, 8 hours. and often combo with inhaled corticosteroid. And there are two. We have budesonide, formoterol, and we have memetrazone, formoterol. This is the only two medication approved for smart therapy because the onset formoterol acts within 5 minutes, so that's what can be used as a rescue as a relief or quick relief medication. And glucotriene modifiers, Montrelicast, singular is the most one that we use all the time because one time you didn't need to worry about much. Zetrolcast, not a lot of people use it because frequency and liver enzymes, other stuff. But you know that the black box warning for this medication, behavioral changes or nightmares, that's something you would discuss. And I'm not sure if they don't add much to the treatment, so the benefits not that high. So not something that I would start my patients on to monitor. Most of the time, this is the first thing I do. I drop this medication on the patient's list. So it's out there, can be used definitely, but don't expect much out of it. And you have the mast cell stabilizer at Promolan. These are the biological agents approved for asthma. You have omalizumab's anti-IgE medication, 6 years and above, and severe for allergic asthma. You have the interleukin-5 receptor antagonist. You have mepolizumab, brizolizumab, benralizumab, and you have a bit of age variation, 6 and above, but 18 for rozumab. You have the anti-interleukin-4 dupilumab that blocks 4 interleukin-4, interleukin-13, and you have anti-TSLP, tezepelumab, and this is the beauty about this. You don't need to have any kind of besides having severe asthma, you don't need to phenotype or have any workup that can be used for any asthmatics not controlled, severe asthmatic not controlled with combo therapy. Patient education, definitely, and part of the patient education, you have inhaler technique with your spacer. Always give your patient spacer at any age. This way guarantee that the medicine gets delivered to where it's supposed to in the lungs. 60% of the time, patient might not get better because either they're not using inhalers or the wrong technique. So that's why every time patient comes, especially first visit or annually, you might revisit the inhaler technique and always ask them about their inhalers. Do they still have it? Do they need a new one? How to take care of the inhalers? So that's something you want to revisit with patients every time. Asthma action plan is something that we provide here to the Mercy, and we helps with patients, especially coming to our clinic. We're doing all these procedures, skin testing, Spiro, NIAX, and they can be overwhelming. And patients going home like have no clue what to do when they have asthma flare-up. So asthma action plan really a good option for them to have at home and to follow, and easy to remember what needs to be done if the asthma symptoms are not controlled. Definitely always about avoiding trigger. If you have multi-trigger factors, then definitely avoid cat, dog, dust mite. And the important follow-up. Asthma is not just one visit, you are done. Sometimes the patient think give them the medicine and they're good to go. No, unfortunately, you have to come back, reevaluate, assess, do we need to step up, step down, continue? So a lot of questions. The follow-up is very essential. And sometimes certain patients or families need multiple visits to understand what's going on. So understanding the situation of the disease help for them to increase their compliance with the treatment provided to them. The asthma action plan is really green, yellow, red. Green means this is what patient expected to do on a daily basis. Could be nothing. Someone is concerned with an asthma, having no symptoms, then they have maybe either if they're going to smart therapy like combo therapy as needed, or maybe they need to schedule like 2 buffs twice daily or 2 buffs once daily based on the medicine. Yellow zone means they're not doing well. It's really say someone who had started to have illness, then you encourage them to step up medication. And we always recommend not to schedule the short-acting beta agonists. So don't ask patients to take albuterol schedule, because sometimes I see patients after ED get visit for 2 weeks, they've been taking their albuterol every 6 hours. They think that's what they're supposed to do. So please don't ask them to schedule, and there's no much benefit to schedule. Even the yellow zone, we don't recommend to schedule. You have symptoms, use it. No symptoms, don't use it. So we want to make sure the patient clear about their instructions that don't use short-acting beta agonist as main inhaler or on daily basis, because then you worry about tachyphylaxis. The patient might get used to the medicine and might not work when they need it the most. Red zone means they're not doing well, not doing very well. So maybe need prednisone, or maybe need to seek medical help, a little bit get evaluated for what's going on. Maybe they need more than what you can prescribe them in the clinic. Always you write the asthma action plan and provide them with a copy, and this is what we do. Sometimes multiple copies, one for school, one for home, or if they have different homes. And it's really beautiful, colorful, that when we have here, so it helps them that green, yellow, red. So it's really nice. I mean, Pete's right, so we like colorful things. When you go to the adult side, we get them one plain. All right. Moving on. So asthma treatment is not sit and forget, and not just medication. So always, every time, want to make sure that you review, assess, and adjust every visit. It's not just one time. All right, so this is the GINA guidelines for 24, and GINA update every year, so there's a new one, 25, available. And to give you an idea, the treatment approach, and this would vary based on the patient's age. This is for 12 and above, and we have for one from 4 to 11, and we have from 0 to 4. And you can see now we have two kind of pathways or track. They call it track 1 is the preferred one, and this is when we have the smart therapy. Means that we're going to use one inhaler, and the two medication in the US, we said earlier, budesonide and formoterol, and the other one is memetazone and formoterol. These are the two medications can be used as in smart therapy. The other combo who has salmeterol, we cannot use it because salmeterol has delayed onset of action, so it's not going to work immediately, so it cannot be used as a quick relief medication. So the beauty about the new recommendation that the first step 1 or 2, so you saw your patient, diagnosed and would say maybe intermittent asthma or mild symptoms, severity, risk factors, and the first one you can still use as needed only low dose inhaled corticosteroid and formoterol. And this is the track 1 preferred. If they say for what reason, cost, inconvenience, medication not available, then the other option would be you would recommend taking, let's say if that's step 2, you can take low dose inhaled steroid, and ideally the recommendation you might use rescue or like quick reliever after using that medicine, or every time they use the quick relief medication, ask them to take their inhaled steroid. Step 4, this one you said medium dose. With step 5, the beauty, this is when you consider biological agents, and this is something I'm going to discuss more toward the end of the summer series about biological agents and severe asthma. If you agree with the same thing but a little bit different approach based on the age, this for X611, and this is for kids younger than 5. So common contributors to loss of asthma control: environmental exposure. Yes, someone has dog and cat allergy, they have a dog and cat allergy, or someone with pit exposure, other exposure at work, or comorbid condition not controlled, sleep apnea or GERD, difficulty using inhalers, and there's different type of inhalers, MTI or the powder, and sometimes you have to make sure the patient can use the inhalers, and they say elderly have difficulty with certain inhalers, you have to take in consideration when you say an elderly patient. Poor adherence definitely is always a problem. That's why you want to make sure that patient understanding of the disease might help to increase adherence or compliance. Inconvenience, yeah, sometimes if you give them something, nebulizer, they're not going to wake up in the middle of the night to use a nebulizer. Even like if you give them, like, I mean, it has the same efficacy as the inhaler, but sometimes may not work. Cost associated, so you have to be a little bit careful when if you send them a very expensive medicine. Guess what? They're not going to take it, so they're not going to use any medication. So you want to always take in consideration the cost associated with the medicine you prescribe. So in the track 1, track 2, that cost could be a major factor in that. And lack of access to healthcare. Yeah, unfortunately, patients live in rural areas. You want to make sure they have access to. So now with telehealth, telehome often that helps a lot. And try to increase their access to specialists. Things to do each visit, definitely. Always confirm asthma diagnosis. Yeah, seeing somebody being diagnosed with asthma doesn't mean they have asthma, right? So always good idea to take quick few questions, confirm this is really asthma, right? And now you know what type of question you need to ask. And always revisit inhaler technique. Make sure do you have inhalers? Awesome. Do you use it? How are you using the inhalers? How often are you using the inhalers? Medication adherence is always a problem. How often? Because we have kids younger, like 10 or 14, poor perceive their symptoms, and then I'm doing well, I do inhalers, and you get the spiral, their function, lung function really, really bad. So that sometimes some test might help you or help the patient to see. Sometimes I print out the spiral and see the difference before and after albuterol, so that little bit visual aid for them to say, yes, oh, I need the medicine. Despite them, like I'm feeling good, like 13-year-old, I'm doing good, I do need medication. Always consider coexisting conditions. Always ask about the allergy trigger. And definitely, by the end of the day, you want to ask, because you want to address any side effects of the medication. You want to ask, make sure that they, for instance, after they have the steroid or any medication with the steroid. And you want to adjust the medicine, either stepping up or stepping down the treatment. Yeah, because the question comes in, if you have someone who has allergic asthma and their spring is the worst time of the year, you do want to step down their asthma treatment despite them doing good in the winter time when spring is here. So you want to make sure wait till outside the allergy season, or someone who's always in the fall, winter is really have bad asthma, maybe not a good idea to step down even they're doing well anyway till a little bit of their asthma season. All right, coming back to the clinical vignette. So what do you think about the 2-year-old male with history of respiratory distress, admitted to the PICU, RSV, and in between, beside the other ED visit, doing well. So what do you think is going on with this kid? Think he has asthma? No asthma?
No.
No asthma, right? I mean, what do you think?
TBD.
Yeah, right?
I think he has respiratory failure. Secondary to RSV.
Yeah, you never know, right? So RSV is really, can make that bad symptom, but RSV is risk factor for asthma in the future. They maybe still, but based on this, I would say maybe I wouldn't just upfront call it asthma, right? I'm not gonna, hey, this is asthma, good luck. Yeah, you wanna say maybe illnesses, wheezing with illnesses or that, but yes, always wanna make sure follow up with them and see. They might be asthma future, it's still possible, but don't just jump and call everybody who wheezes or coughs asthmatics, right? All right. See what we see: a 7-year-old female where we start to cough at night and while playing soccer outside in the springtime. So what do you think? Asthma? No asthma?
More concern.
Possibly.
Possible asthma, right? Let me say the cough start early night, not midnight, not early morning, and just what do you think?
That's less concern.
That sounds right. So upper airway concern could be just right nights, season allergies, coughing because she's a lot of nasal drip, right? And whenever she goes to sleep, a lot of nasal drainage. Yeah, if there's no other history, no other symptoms, I mean, so yeah, it's early in the game, so most likely upper airway syndrome. Yeah, definitely you would say, with the playing outside spring, soccer, yeah, you gotta take more information. Is it, when you also ask them, is it from here or from here, the cough? Because sometimes that might a little bit help, like could be upper airway syndrome, pushing to kind of cough. So it's good to ask. Okay, we have the 14-year-old female with history of difficulty breathing with prolonged activity. Otherwise, she's doing well. No, let's say no hospital admission, no ED visit, no oral steroid, only with activities. What comes to your mind? Yeah, extranditional fast, or it could be asthma, aggravated, right? But cardiac disease, you always think about congenital undiagnosed cardiac problems, visual activities. So you want to always ask, don't just, coughing, yes, she's asthma, and just take medicine, good luck. You want to always ask, take good history. I know, the teacher at school, take good history, we still teaching everybody, it's all about taking a good history. That helps you a lot to reach the right diagnosis. We don't spend enough time with the patients taking good history. You're gonna spend a lot of visits and spend a lot of money with fancy tests that may not help at the end of the day. So always about taking a good history help you to reach the right diagnosis more than 70% of the time, right? So we have 20-year-old male with history of allergic rhinitis, wheezing, chest tightness up to 5 times a week, improve with albuterol. What do you think? Right, this is maybe, this is a we'll asthma fun, right? Yeah, I'll get PFTs and this is classic, but we need to help him because we cannot just keep doing this, right? Can I use our little 5 times a week, right? We gotta a little bit be smart and maybe smart therapy, right? All right. And that's conclude, I think, our lecture for the day. Any questions? But it's not one move now,